This is Dr. Charles Parker, and you're listening to CoreBrain Journal. It's a place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street.
Well, here we are, folks. Welcome aboard to one more visit with CoreBrain Journal. And as you know here, we're really interested in bringing the bench down to the trench. We want to really get the neuroscience experts, and we have a noteworthy, nationally known neuroscience expert with us today who happens to be an old pal of mine. I'm really happy to introduce him to you, Dr. Robert Hedaya. And Bob is going to tell us about what he's into and what he's interested in. I'm going to do a brief introduction, and then we're going to really get down to who Bob is as a person, what he thinks we need to do to really grow our understanding of mind science down to the grassroots, down to the public. So I'm going to read this, but here it is. It's a lot. Dr. Hedaya has managed an active private clinical practice while also teaching at Georgetown University Medical School, where he is a clinical professor of psychiatry. He's been a consultant to the National Institutes of Mental Health and was selected to teach the first psychoendocrinology course at Georgetown University Medical Center, the Department of Psychiatry. He is invited to present and teach at medical professional conferences worldwide. He also, this is an important point, folks, stay with this point. He also conducts no-cost monthly workshops by phone for both medical and mental health professionals and lay people nationwide. Bob is on the same path we all are here. Dr. Hedaya has been featured as an expert consultant numerous times, including television appearances on The Today Show, Fox, CBS Evening News, 2020, MSNBC, and CNN. And these are some of the books that he's written. We're going to go speak very briefly about it, but he's received the Physicians Recognition Award from the American Medical Association, Outstanding Teacher of the Year multiple times by the Georgetown University Medical Center, Department of Psychiatry. One of the ways I first met Bob was we were at a conference together and we had a great Italian dinner together. It was a really special evening. That was many, many years ago. Bob and I were just talking about it offline before we started here. So his first book in '96 was Understanding Biological Psychiatry. So he was an innovative thought leader early on. Then the Antidepressant Survival Program came up in 2000. And his third book, Advancing the Treatment Paradigm, 2008, with the Institute for Functional Medicine, where he is a member and works over there with Dr. Mark Hyman, who many of you know. He's a teacher over there as well. So with that, Bob, thank you so much for joining us. We look forward to talking to you. Now, hey, Bob, it's interesting because I'm not getting your voice in here. So let's see, because you were there a minute ago.
Is that better?
Yeah, now I can hear you.
Okay, I took the mic out.
Okay, good. So the issue would be, let us in a little bit, Bob, to what you're doing right now. That's the background. What's your personal life like right now, your practice, things you're interested in?
Well, so what I'm doing now is doing a lot of work as a medical detective. I'm taking people on who have medical problems that they can't solve, and trying to spend several hours with them, review their records, and get under the hood, really, to figure it out. So, for example, I had a patient who came in who had a complement disorder, and she came in and she was having anaphylactic episodes.
Now, stop right there. Our audience doesn't know what a complement disorder is.
Okay, well, I'll tell you what.
Okay. Take a moment.
So basically, this is a patient that I had several years ago who had a manic depressive disorder, and I treated her and she did very well. And then she came back to me because she was breaking out in hives and she was having to have EpiPens. She was, in case she had anaphylactic shock and couldn't breathe. And so she's having these episodes constantly, turning red, having hives all over her body, and couldn't really figure out what was going on, and pretty much terrified her and took her out of school. She wasn't able to continue in college, had to move back home. And so we sat down for about 4 hours, and I went through the history with her, and turns out that she had a disorder of the immune system in which there was an overreaction, well, let's say a reaction to some kind of a infection, right? But her body was unable to turn off the reaction.
Very good.
That was a genetic problem of which I uncovered. So basically what really turned out is pretty simple, is she had this genetic disorder, but it never really caused a problem. Then she got Lyme disease. And then when she got the Lyme disease, it unmasked this genetic problem. Now, when she came to me, she didn't know she had Lyme disease, and she didn't know she had the genetic disorder. So we sorted through the medical mystery, calmed down the Lyme disease, treated it, and things settled down, not only because we treated the Lyme disease, but also just knowing psychologically what was going on. She no longer felt out of control. And so that's medical, I'm a medical detective.
That is so interesting, Bob. You know, now that you brought up Lyme disease, and I know we're going to be talking about inflammation because both of us are very interested in inflammation. And I really want to tap your brain a little bit while we're here because it's going to be good for all of us to learn some of these innovative new insights that you have. But I'm curious about, since you talked about Lyme disease, about your thoughts about biofilm and colony formation as it relates to not only Lyme but Candida. I'm diving kind of deep right now, but since you brought up this very interesting case, I thought it'd be fun to hear your thoughts about it.
Well, I won't say that I'm an expert on biofilm. I mean, I know, biofilms. We have biofilms all. That's part of life, right?
Mm-hmm.
We exist with biofilms, and bacteria obviously use these slimy environments to stay alive and evade our antibiotics, and our immune system attacks on them, and it's very effective. But it is, part of life. Now, how do you dissolve biofilms and get the antibiotics in there and all the nutrients or whatever it is you need to get in there? Well, if I knew that, then I would probably have a Nobel Prize. So
yeah.
I don't know. The things that I've learned about is, that xylitol can be effective in dissolving biofilms. Mm-hmm. Just read something, actually, it's funny you brought it up, but that copper itself can also dissolve biofilms. But, those are just anecdotal. I don't know if they'll hold up or anything like that.
Yeah, it's very interesting, and I know it's controversy. Sorry to put you on the spot a little bit with that because I've been reading about it myself, and I know very little about it, but I'm interested because I've been following it a little bit and see it's so relevant to people who come back with the IgGs that are off the mark and major Candida, mm-hmm. and we then try to attack the biofilm. Just for the listeners who don't know, what happens, these bugs actually talk to each other, and it's called quorum sensing. So what happens, they start talking to each other, and there's a great TED Talk about this, by the way. And mm-hmm. and what happens, these guys are talking, and then they form a colony, and then they put up, in the old days, Bob, you and I are old enough to remember the Pepsodent ads, the knock knock invisible plastic shield. This is what Pepsodent does.
Right.
And so the biofilm does that. So, well, I won't belabor that more, but let's get over into the subject of the whole thing of how you got into this new way of thinking about psychiatry all the way back in 1985 is when we started with this. That's right.
I went into practice in 83. And was doing, standard psychiatry at the time, and the cutting edge was cognitive behavioral therapy and psychopharmacology, and that's what I was doing. And then I had a woman come in with panic disorder, and I treated her with all the standard stuff. I mean, first I tried cognitive behavioral therapy, and that didn't work, and so I tried imipramine, and that didn't work, and then I tried Xanax, which I thought for sure would work, and that didn't work, and one thing after another. And then a year into her treatment, she paged me. Those are the days when we had beepers.
Yeah.
We thought those were pretty cool.
Yeah, right.
And she paged me. I was at a wedding. I was dancing, and my beeper went off. And I said, well, I got to check. And it was Joanne. And so I called her, and she said she was in the middle of a panic attack. And I was thinking, like, wow, what's going on? She should have been better a long time ago. So I went into the office early Monday morning to look at her chart. And I noticed, I had done a complete blood count and a chemistry, and I noticed on her complete blood count that the size of her red blood cells was a little bit large, very slight. The range is 80 to 100. It was 101. But I learned in my training to ignore that because it was not that far out of the range, and who knew what it meant anyway. And I was glad.
Oh, yeah.
All right, that's how I was trained.
Yeah.
And anyway, I did a little research and saw that it meant she could have a B12 deficiency. So I did a Schilling's test, which is no longer available, as you know, and she had a B12 deficiency. I gave her B12 injection, and with the first injection, her panic disorder was gone. So
amazing.
I was blown away, and I realized at that point that the head is connected to the body by this thing called the neck. And
I love it. Bob, I say that all the time.
Right.
I mean, it's so much fun. The last time I checked, the mind was connected to the body.
Yeah, it is. I mean, it's remarkable. So, I guess we both missed that lecture, right?
Yeah, right.
That lecture never happened.
It didn't happen.
So anyway, that kind of opened the door. And then in probably after my first book, I actually was on the edge of chronic fatigue, and that kind of freaked me out a little bit, and so I started digging deeper to see what I could do and learning about it, and one thing led to another, and I treated myself and recovered quickly and fully, and got involved in functional medicine, and that was in probably 97, and that to me was just I don't know, like going home. It made complete sense. It's systems medicine. It made sense in terms of personalized medicine. Everybody's extremely unique beyond what we can even conceive of. Understanding that, everything is affected by everything, and really trying to grab hold of this mass of information and not looking at things through a very, very narrow lens, realizing you need many tools. And so anyway, I delved into that, and it was a little bit overwhelming at first, but after about 3 years, I had really felt that I mastered it and started treating people, and my motto became better health, less medicine.
And that's interesting, because I'm while you're talking, I'm remembering being at a meeting back when I was doing brain scans up in D.C., and I was still more on the traditional side. But one of the reasons I wanted to work with Eamon is because he was really looking at functionality, at brain functionality, and there was some evidence associated with it. And I went to a meeting up there and down at what am I trying to say? Right there in Reston, and so the guy next to me, I'm like nodding my head because it was one of the first functional medicine meetings I had been to. It was before I'd actually gone to the Institute of Functional Medicine. And I'm rolling my eyes a little bit, trying not to roll my eyes because I want to look like I know what I'm doing, And he says, we had talked, he says, "Hey, Parker, you look like you're not quite with it." I said, "No, this is completely over my head. I don't get it." He says, "Listen, it'll be that way for about 3 years."
That's right.
and then somewhere it will dawn on you that this is the way it is.
When I used to listen to these tapes by Jeff Bland.
Yeah.
In the car, and I'd have to pull over to the side of the road every 5 minutes to make a note about this patient or that patient, and it was overwhelming. But by the time I got trained, it was all there, and it just came together with the training.
Well, I think it was really good, Bob. Also, you mentioned in our notes and previous talking that you really decided to go ahead and get a scorecard for yourself and see what's going on, and you actually measured depression. And you say, okay, how much is really helping? What I'm doing, is it good? Is it indifferent? And you did the Beck Depression Inventory on a series of people. Could you tell us about that?
Yeah, well, what I did is I did a retrospective analysis of 100 patients that I had used functional medicine approach. They all had depression, and my practice was such that they were all treatment-resistant depression, meaning they'd been through multiple meds. They were on medication when they came to me. Things weren't working, and they were all moderately to severely depressed. And the average Beck Depression Inventory, which should be under 10, is normal. The average for all 100 was 34. I treated them with my method, the functional medicine, I call it whole psychiatry method. And by 10 months, they were all, except for one patient, under 10, with no medication changes, except for one patient who I put on lithium. So with the functional medicine method, they all normalized. And that's powerful, and actually I should really write it up. I didn't write it up, but I should do that now. I just found a good writer, so.
Well, it would be a good thing, because it's funny to move the needle forward. People look at what are the stats? What did you do? I think people really are looking for answers, especially from a person like yourself who's had so much experience. What does Dr. Hedaya do when he sees something like this? What are the 3 things he thinks about right off of the bat? What's the first thing that comes to his mind, second and third, and then how does he break that down over time? One of the things that happens is chronic illness takes chronic fixing. You just can't come in there, and a lot of people are so used to feeling a little bit better with a couple of meds, and they get disappointed by the fact that these things take time, 6 months, a year, maybe 2 years, to actually turn the whole situation around. What are your thoughts on that?
My feeling is this, that once you have worked out the program, you've evaluated the person, you've gotten your lab data, you know what's going on, and you implement the program. Once you're implementing the program, if people follow it, and that's the big if here, because we have most of the information we need to deal with chronic illness. Okay? We have most of the information. The big if is, will people do what they need to do? But if they do what they need to do. In that series, it was 10 months, they all returned to normal. And I'll tell you another case with a guy who was 18 years old with OCD. He came into my office with a contracture of one of his fingers, so he couldn't straighten his finger because he was afraid for 2 years that if he straightened his finger out, something bad would happen. So he had this severe OCD. So, long story short, I evaluated him, and he had 5 different infections.
Really?
Now, 5. Now, as you know, infections change the brain chemistry. So I treated his infections, and with that treatment plus some basic behavioral therapy, in 3 months, he was normal, and he went to college. No meds.
That's amazing, Bob. That's fantastic. Now, this is a tough question. Do you remember some of those infections?
Yeah, well, I remember some of them. One was a chronic salmonella. One was a candida.
That's enough right there.
That's true, but he had 3. I think he had a chronic sinus infection, and I don't remember.
Some other like really overt bacterial thing going on,
Yeah.
So it's amazing because we see that all the time. My favorite question, Bob, you'll get a kick out of this. I know it's probably your favorite question too. You and I haven't been so personal as to talk about this, but as I work through, I'm still doing traditional psychiatry. I'm kind of over in that club, looking at being in the middle of the club between traditional and doing the comprehensive thing. So I asked the question after we get the initial thing, how many times a day do you go number 2? And I get so much mileage, and of course I document it with the Mayo Clinic. The Mayo Clinic's written so much about transit time, right. and we get that transit time on there, and it's like, oh my gosh, I do have a problem. It's as simple as that.
Right. It's I just gave a talk at the National Chiropractic Leadership Conference in D.C. here last Friday. And one of the questions, I went through the whole functional medicine matrix with digestion and immune function and detox and nutrition and hormones and genetics and epigenetics. So somebody said to me, well, if you had to pick one of those systems, where would you start? And of course that's difficult, but really what I have to come down to is the gut.
Yeah.
Because every meal is an antigenic holocaust.
I love that. I haven't heard that before. Isn't that amazing? Yeah, so true.
Every meal. But we're prepared. If we're healthy, we're prepared to deal with it. If we're not healthy, it really creates tremendous inflammation and downstream consequences.
That is amazing. We're definitely on the same path. Well, I'm also interested, Bob, and I want to make sure we get in a little conversation about some of these new things that you're interested in. I mean, you've seen the good, the bad, and the ugly. You've been involved with a number of really, not only as a person being educated, but you're training some of the thought leaders in the country on a regular basis. What are you doing now with your time? What's your next project that you're involved with that you think could be a contribution to science and the science of mind?
Well, it's a great question. So I'm actually now looking at turning my sights towards dementia. I had a case where there's a woman who had a mini mental status exam test I did on her. She was 14. For your listeners who don't know, the normal is a 30. So if you're a reasonably functioning human being, and we test you on this very simple test, you should score 30. She was about 65 and she scored 14, and she would get dressed and put her bra on over her shirt and think nothing of it. So that could kind of tell you how bad things were. So I treated her with this paradigm, this functional medicine paradigm, and after, I would say it was about 5 months, her mini mental status exam increased to 28. So she was just shy of normal. And it's remarkable. And I have come to believe that in mild and moderate dementia of the Alzheimer's type, I don't know about whether frontotemporal dementia or other types of dementias will respond, but I have come to believe that a significant portion of people who have early, say, mild cognitive deficits, or early Alzheimer's or moderate Alzheimer's, that they can actually, if they have somebody who will help them implement the program, that they can actually be, that can be reversed, certainly stabilized, and many people can return to full function. In fact, there was a case series that just was published in Aging, the journal Aging, by Bredesen, and out of the Cleveland Clinic, and he documented 10 cases where he had reversal. Well, 9 out of the 10 had reversal, significant reversal with this methodology. So that's really where I'm turning my focus to, preventing and doing some reversal of dementia.
That's so interesting. I hope you write about it. I'm looking forward to that book, because
I'm actually writing a case study now and talking about thinking seriously about writing a book. So
that'd be great. If you, when it's published, please let me know. We'll put that on the show notes, and we'll make sure that our listeners get a chance to have some access to it. As you were speaking, I was thinking about asking you the question. Of course, we know that the Alzheimer's type of dementia, we don't know about it, but it's all the directions going into inflammation. How does inflammation play out with traumatic brain injury and those guys that are coming back from the Middle East, and actually, I mean, not just those guys, but people who experience a traumatic brain event? What are the implications for inflammation with that, Bob?
Well, I mean, the data, I mean, there's so much that isn't known with that, but I mean, the data is that there are changes in all the neurochemicals, really, and you have glutamate excitotoxicity, you have changes in microglial function, you have changes in the neuronal networks, the meninges can be involved, changes in blood flow in the meninges, all of these metabolic changes. So, that's... and that could be mild or that could be severe. It's and that can unmask other illnesses that people have. I have a patient who has a mast cell activation disorder.
Oh, that's
that's becoming a big deal these days. And the TBI, the traumatic brain injury, unmasked her mast cell disorder.
That mast cell is so interesting. One of the interesting things that I've been seeing apropos of that point, but is the fact that so much of the brain deterioration and brain fog is related to just straight candida.
Right.
It's amazing, because you can have a relatively non-chronic person with a deterioration that's just flaming with candida and has been that way for a long period of time.
Right.
So what are the tests on your Alzheimer folks, on the people that are really chronic? What's kind of your main go-to test that you want to start with, one or two, that you think would be important for listeners to consider?
Well, I mean, obviously, first you have to make the diagnosis, and you can't really know if it's Alzheimer's. You could do a genetic test, the ApoE testing, but I really think you need to, as a clinician, or if you're a patient, you're going to a doctor, you're taking your spouse to a doctor, somebody needs to sit down for a good, at least an hour and a half. I mean, I spend about 4 hours with my patients the first time, but at least an hour and a half, and think through these different systems that I mentioned on this functional medicine matrix, and try and identify where are the symptoms. And then when you have identified which are the main nodes or the main systems that are involved, then you decide which test to go to. So you're certainly always going to need a thorough nutritional battery, for sure. Mm-hmm. Most of the time you're going to need to look at the GI tract, and you're also going to need to look at the hormones, mm-hmm. the thyroid, the adrenal, the melatonin, insulin, very important in dementia. So you've got to look at all that. Inflammation, cuts across disorders. I actually developed a product about 4 years ago for inflammation. After it seems like my own health problems just keep.
They keep you plugging along. They make you look at the books, buddy.
They really do. I tell you, I had a biking accident. I'm a mountain biker, and I injured myself. I had a sudden, severe, searing sciatica. I was in the park, Rock Creek Park in D.C., and a car came behind me. I had to hit the pedal fast, and it was a knife in my back. And anyway, I didn't get better, and so all the standard stuff was pretty much useless. And so I put on my functional medicine hat, and I said, it must be inflammation. It's got to be inflammation. It's a chronic illness. Mm-hmm, mm-hmm. So I started to test different herbs on myself, and ultimately, after a number of trials, I came up with a formula that in 2 days had me better. Literally 2 days. So I thought, well, it can't be this. It's got to be, I'm better. That's all. I'm just better. So I stopped it, and then, of course, I got, it came back. The pain came back. So it did off on, and then I was convinced that this formula was really effective. So then I thought, well, the raw materials must be doctored. They must be something contaminated, or they must be putting some kind of drug in these things, because it's too effective.
It worked too well.
So I sent it to a lab to get it tested. It came out clean. And so I started to give it to patients and family, and patients wanted it for their mother and father, etc. So now I market it. Somebody tried it, they loved it, they invested in the company, and so now we market that.
So let's talk about that a little bit. What's the name of that product, Bob?
It's called Rejoint. It's DR, like Dr. H, Rejoint, because it it helps. Renew your joints. So we call it Rejoint.
That's great. We're going to we'll put that on the show notes so people can pop right in and go over to the website and take a look at it.
Yeah.
I'm going to work with you on that too. By the way, I looked at the website and I'm like, oh my gosh, I've got to get hooked up with Bob on this, because we see so many people who are suffering from chronic fatigue and the kinds of things that you're talking about that are indications for it, that it helps. And it's not good for everybody. Nobody's making any big claims about it. Right. But look, it's better than what doesn't work.
Right. No, it works. Just being frank, it works. We have a 70% reorder rate, so that pretty much tells me it's working in about 70% of people. And so it's not for everybody. It's for people who have chronic pain, arthritis. I could go on and on about the stories about this stuff, but it's if you're having chronic pain or joint problems, or we've had great success with Lyme flares. People have Herxheimer reactions with Lyme. People take it during their flare because it basically blocks, if you know TNF alpha, which is a really primary molecule, and NF-kappa B, which is a grand central station molecule of inflammation. So, and then it also normalizes 8 other pathways. So instead of taking, say, Advil, which works on the COX enzyme, or say codeine, which works on an opiate receptor, this actually works at parallel pathways, and as herbs do, it normalizes things. It doesn't suppress things. So anyway, we love it.
Well, we're looking forward to it. I just want to clarify for people who are listening, because some people don't know what a Herxheimer reaction is. And really, it's when Dr. Hedaya said it was a flare, you can have a Herxheimer reaction from a number of different things. You can have a Herxheimer reaction from losing weight. I've seen people deteriorate dramatically psychologically, losing a lot of weight, because it just lets those toxins come into the system. You want to say a little more about the Herxheimer reaction, Bob?
Yeah, the best, I just thought of this, but I think this is the best description of a Herxheimer reaction, is how you feel when you get the flu. Mm-hmm. You feel feverish, achy, you don't want to do anything. You feel like somebody just beat you up with a rubber hose. Every inch of your body hurts, your joints hurt. You don't even want to move. That's the way it hurts. It's not a cold, it's a flu, if you've had the flu.
Well said.
That's what Herxheimer's like.
Well said. Thanks for sharing that. That's a good point. Yeah, we've seen them go so bad they can all of a sudden have a bad case of diarrhea. They can get vomit. They can have, that's if you're killing the bugs too fast. What am I trying to say? Actually, identifying the problem and doing something about it mobilizes the toxins that were either in the bugs or in the body fat, and you can feel it dramatically throughout your body.
Yeah, it's the lipopolysaccharide is the envelope of the bacteria, and the lipopolysaccharide envelope actually increases the body's release of chemicals, these molecules, the cytokines that cause inflammation. So your whole body becomes inflamed as a normal, really a healthy response to trying to get rid of all these toxins, like you were saying.
Well, and as you were saying, Bob, I think that people don't know what a cytokine is. A cytokine can actually compete at the receptor site for the neurotransmitters. So, you can be feeling pretty well, but if your serotonin isn't hitting its receptor site effectively, because cytokines are parading around on the receptor site, you can feel like dirt all of a sudden when nothing else has happened. And
right.
So it's a pretty, not pretty, it's extremely interesting to me, because we just see it all the time with treatment failure, and that's what we're with you on that, Bob. We have a lot of, it's actually fun, because you see people getting better that previously have bounced around with whatever, have decades of this or that with symptoms. I'll tell you the one thing, you get a kick out of this, because I've been back to the poop and the gut thing. So asking the number 2 question, a guy comes in and he's a very macho hot dog project manager, guy's guy. So I asked him the number 2 question in the initial interview. He says, I go every day. I've gone every day since I was a kid. So I said, well, I gave him some meds. We covered some issues. And I said, look, you got something else going on here. He said, no. Bottom line, his wife was going to get divorced because he was losing it, and I was giving him good psychiatric medications. He was losing it. I said, let me go over this one more time. I think you really, number 2, how many times a day do you go number 2? He says, Parker, I think you're anally fixated. and I said, well, humor me. Can you afford 69 cents? This is not complicated. So we do corn. We just have corn. Eat the corn, look at your watch, and see how long it takes to hit the toilet. So he comes back, and he's back in 2 weeks for a med check, and he says, I hate to tell you, you were right. I said, well, how right was I? He said, I ate the corn on Friday. It didn't come through for 10 days.
Whoa.
End of conversation.
Whoa.
Or the beginning of another conversation.
Yeah.
So it's funny. It's fun using stuff like that. So, well, listen, Bob, I want to really thank you for taking the time. We're going to be doing this again with your permission. Your input is valuable. I'd like to sometime in the future talk more about rejoint and your experience there, and see what some other applications for it, because it sounds very interesting. A thing that occurs to me as you were talking would be would that rejoint, because it is anti-inflammatory, how that would work with some of these other conditions that are mind conditions that have an inflammatory etiology. They come from an inflammatory source.
Right.
It'd be interesting.
Yeah. Now, well, I'll say this: we've had a couple of people report to us that they've had changes in mood, but I can't say to you, "Hey, you've got a depression. Take rejoint."
Yeah, right.
Say that, because one of them got a better mood and one of them felt worse.
Yeah. So then that's a whole nother thing. Yeah.
Yeah.
It's amazing. I'll just say, in closing, one other thing I have to tell you, I'm very interested in Dr. Walsh's work, in the methylation process. I mean, I've spent some time with him. We'll talk more about that later. But one of the things that comes up, I just was not. You've probably been interested in pyrroles for a long time, but
yeah,
I've been interested in that for about the last year, and it's just amazing because you see these odd reactions to what would be a thoughtful, should be predictable outcome. And then they've got these other things going on that just were not predictable, and you had to measure them to find out what they are.
Yeah, well, one of the things I do when I see somebody is I do a physical exam. And one of the things, particularly in adolescents, you look at their nails, see if you see these white spots, because that'll tell you the zinc deficiency. And then you wonder about the cryptopyrroles, and because, you have a zinc deficiency in that kind of scenario. And then the adolescents, their bones are growing so fast that the bones take all the zinc and the brain doesn't have enough zinc. And, then the serotonin receptors, the serotonin signaling is impaired because you need zinc to have adequate serotonin signaling. So you look at the white spots on their nails and you go, okay, maybe they have a cryptopyrrole problem and they certainly need zinc. And, there's all these things that you're aware of, that I'm aware of, that people who are going to their docs for, whether it's psychiatric, emotional stuff, or other, these things need to be looked at.
Bob, you are so right. I can't tell you how much I appreciate your being with us this afternoon. And we're going to have all the links for all of your books right there on the show notes. And we're going to encourage people to hook up with you and follow. I'm very interested in the presentations that you do for the public. That'd be a very interesting thing. Do you run that through Blog Talk Radio, or how do you actually
No, we record here. We have on our website, we have a few websites, but the whole psychiatry, like Whole Foods, whole psychiatry website is 200-page website. We have video lectures. We have, 30 radio shows. We have like 30 lunch and learns, articles. There's a lot of resources there. And then we have the DRH Rejoint website also. But there's a lot of stuff for people to sort through. And we leave it up there. We hope it's helpful.
I'm sure it is. It's helped me out. I just went over there the other day and found out, some additional stuff. Could see where we really are connected in a lot of ways. So thank you so much again, Bob. I've said that a couple times, that there's always more to talk about. You're a guy that we can't end the conversation with. So I look forward to another time that we can talk. Thanks so much, and we'll talk soon, Bob.
It's a pleasure, Chuck. Take care. Thanks
for
having me.
Okay, you have a good one.
Thanks for listening to CoreBrain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive, misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at CoreBrainJournal.com/start. Thanks for listening. Do connect and stay tuned.